is Dr. Manuel Cunanan. Dr. Manuel Cunanan is board certified physician in pulmonary medicine, internal medicine, and critical care. He has over 24 years of experience in this field. He specializes in COPD, atypical pneumonia, and excessive daytime sleepiness, and lung metastasis, and chronic cough and pleural effusion. The topic he is going to be talking about is asthma and lung diseases with age. So Dr. Manuel Cunanan, it's a pleasure to have you with us.
Myself, my name is Manuel Cunanan. I'm a local pulmonologist working in the Gloucester area and Cumberland County area. I wanted to thank Dr. Al-Bugani for inviting me here to speak today. It looks like I'll be part of a lecture series in the next hour or so between cardiology and Dr. Colombo. So hopefully I can try to make all of this interrelate a little bit. So when I was asked to speak today, I really wasn't sure how I was going to interrelate with all the other speakers. So I figured we could talk about something that interrelates with what we're doing in the office, and also a little bit about what you guys do with the aesthetics and wellness care. So again, I'm a pulmonologist, so we're going to talk a little bit about asthma. And asthma was always the question, is it always asthma, right? Is that the real diagnosis? So we'll talk a little bit about asthma. So asthma, as you guys know, is a chronic respiratory disease, and it's really characterized by the narrowing of our lung airways. Really, it's typically caused by, I was in front.
I don't know. I thought we had it.
It's typically caused by inflammation as well as overproduction of mucus in the airways. Symptoms, as you guys know, in your clinical practice, shortness of breath, coughing, wheezing, and chest tightness. Those are usually the key features, right? But as we learn through our medical careers, those symptoms are pretty vague. They could be intertwined with other diseases. Like I said to you, the causes of asthma usually is a cascade of events from inflammation, right? So when we have inflammatory cells, they activate our immune system, and they produce T cells, mast cells, neutrophils, eosinophils, right? And this goes through a long cascade of process that causes all those symptoms that we were discussing. Overproduction of these inflammatory mediators, cytokines, proteins, all of these, such as leukotrienes, histamine cells, as well as prostaglandin, all of these will cause the symptoms and narrowing of the airways. therefore causing asthma symptoms. The other things that we talk about is airway hyperresponsiveness. So the airways are actually very hyperresponsive to all the triggers that we'll be talking about. Usually it's exercise-induced or some sort of allergen that causes the airways to become very reactive. Airflow obstruction, bronchoconstriction, all due to narrowing because of the overproduction of mucus. And finally, if we don't correct all of this, we end up with airway remodeling, where the airways actually become stiff and hard and don't function that well. And that's why we get shorter breath, and ultimately the lungs tend to deteriorate and fail. How do I diagnose this? Well, the main thing is to try to talk to your patient. Clinical history is most important, just like in anything that you guys do. Family history of any asthma or any other pulmonary disease, that will also help make the diagnosis. We have fancy tests, allergy testing, pheno testing, nitrous oxide testing. Pulmonary function test is our mainstay tool in the office. And then we also, you can use methacholine challenge test to really provocate and see if the patient truly has asthma. So, a very busy slide, but probably not projecting that well all the way to the folks in the back. But our whole body system, all of our organs, our connective tissue, are all lined by the epithelial wall, right? And it's not only for the lungs, but also we have it in our skin, we have it in our gut, all have these epithelial lining. When the epithelial lining in the lungs is invaded by pollutants, allergens, infections, they all cause all those inflammatory processes that I was talking about. And this is what this slide typically depicts, is that once these mediators are activated, it causes a downstream cascade of overproduction of mucus. So, again, I've been working now probably about over 3 years with Dr. DePace in his office, and I get a lot of patients from that side of the building. And I always get the patients who come in for shortness of breath, right? So I wanted to present to you a case about a patient with shortness of breath, and feel free to ask any questions throughout the discussion. So we have a 30-year-old. She comes to visit, Mrs. Simpson, and she comes to visit the office for her initial visit. Her chief complaint is shortness of breath since 2023, so a couple of years, okay? It's been progressively getting worse. She also complains of a little snoring, weight gain. She complains of a rash, constipation. She has a history of asthma and allergies, apparently since she was a child, since age 6. Unfortunately, in 2023, she suffered a motor vehicle accident a couple of years ago, pretty traumatic incident. And since then, she's developed chronic pain because of the various injuries that she incurred. Her history for her family is significant for her mother, who also has a history of asthma and allergies. She's had no known surgeries, social history. She lives with her family, her children and her husband. They have one dog, which doesn't seem to bother her all the time. And she's a never smoker. And just like we always talk about, she works for the insurance company. My favorite people, right? They work all for the insurance company. And she has no known drug allergies, right? So at this point, what are we leaning towards, right? This is probably, she comes to see me because she's a pulmonary case, right? Well, that's what we all thought. That's what I started to think when I started seeing patients, but not when I see Dr. DePace's patients, because they're not coming in for pulmonary issues, right? So we think. So I don't know if you guys know Mrs. Simpson. This is Mrs. Simpson. You guys met Mrs. Simpson? All right, so Mrs. Simpson comes to the office, and we do a complete pulmonary workup on her, okay? Her allergy testing was negative. She has no elevated eosinophil levels. Her pulmonary function tests were pristine. No airflow obstruction. We did a methacholine challenge test. That didn't show any hyperresponsiveness. So it was a negative test. Her sleep study showed very minimal sleep apnea, okay? And her chest x-ray that we performed was absolutely clear. So at this point, we had nothing, right? What do you guys think? I'm still lost, right? Because apparently her cardiac workup was also unremarkable. So at this point, I don't really have a go-ahead diagnosis, but maybe she has some asthma. Maybe, I don't know. Physical examination, pretty much unremarkable. Really, no acute wheezing, she's not in distress, and her belly was not tender. Her extremities didn't show any edema. Unfortunately, and maybe you guys can see, because this is why we're here today, right? You guys look at rashes all day long. So this was what Mrs. Simpson came in with. A lot of rashes, usually in the chest, sometimes in the face, extremities, right? And I know that Dr. Soloway sees rashes all the time, so he'll be talking about rashes down in the upcoming lectures. But for you guys are also looking at this too in your office, I'm being told, right? So now I'm being puzzled here because this is not a cardiac problem, nor is this a pulmonary problem, because I don't know what this is. But the only thing I know is that she's been complaining of shortness of breath. So, again, let's review. What have we discovered from Mrs. Simpson? We know she has shortness of breath. We know she has rashes. We know she has some abdominal discomfort. And we know she was involved in some traumatic event approximately 2 years ago. But the topic is it really asthma, right? Well, my question is shortness of breath, does it always come from the lungs or the heart? Or the heart, right? Not necessarily, okay? So like I said, in the last few years that I've been working with Dr. DePace and Dr. Colombo, I started to find out that there's something else. And really, when we were in medical school, we really didn't know what this topic was, right? And how does it relate to the world that I live in pulmonary? So that's why I decided and became more curious to figure out, what does this mean? What is autonomic dysfunction? And you will hear lectures in the next hour about autonomic dysfunction, so I'm briefly going to touch on it. But basically, it's an imbalance between our two nervous systems, parasympathetic and sympathetic nervous system, right? And it's caused by some sort of stress, right? So they determined that any type of stress, infection, traumatic, PTSD, mitochondrial dysfunction, any type of stress, just like you were talking about that stress is causing my hair to fall out, right? Or I thought it was my kids, but now I'm finding out it's stress, right? But it's the same thing. Stress is causing these autonomic problems, right? And in turn, that's what's causing our shortness of breath. The only problem is that our patients want us to give them a pill and say, this is how you fix it. But as you guys know, there is no quick fix for this problem. I'm understanding now it's a very slow, methodical process, and there are non-pharmacological treatments and pharmacological treatments. Hydration is definitely a key component in order to have successful treatment. So, continuing on, what does this mean? Well, I told you guys before that we're talking about the endothelial system, right? And that system houses our immune system, okay? And it covers not only the lungs. So now, I'm not just talking about the lungs, I'm talking about the whole body, because I want to introduce that shortness of breath is not just from the lungs or the heart. So the endothelial cells has endothelial cells as well as nitrous oxide cells that are embedded within it, and they're the gatekeepers of our epithelium. If these levels go in an imbalance, it starts to create problems for us, okay? So, one of the biggest cells that are embedded inside or in our endothelial wall are these things called mast cells. And I'm sure you guys have all heard of mast cells before, but we'll review. Mast cells are an important part of our immune system. They are part of our white blood cell system, and they're primarily found in our lungs, our skin, and our intestinal wall. And they are used in the upregulation of histamine and also other cells that are involved in the endothelial wall. But for the purpose of this talk, the reason why I introduced it is that mast cells are important in what we're talking about, which is that you can have mast cells that will be produced in an overabundance. And when they're produced in an overabundance of cells, it will create an overproduction of histamine release, okay? So you can have this problem where you can have mastocytitis, where there's an accumulation of these mast cells in abundance in your connective tissues, as well as you can have mast cell activation syndrome, which there are too many mast cells, which can cause life-threatening anaphylaxis. So again, since I told you that mast cells are found in all the connective tissues in our vital organs, overproduction can potentially cause anaphylaxis. Symptoms that we can see with overproduction of mast cells, for the lungs, we see that they can become more short of breath, they can start coughing, they can be wheezing. In the heart, unfortunately, we can have tachybrady syndrome, where we have elevated heart rates as well as bradycardia, or you can have fluctuations in the blood pressure. In the gut lining, unfortunately, people have reflux symptoms. They also have diarrhea, bloating, and constant abdominal discomfort. In our skin, we start to see patients who end up with hives in the malar region as well as in the arms. And people complain of headaches as well as having confusion and anxiety as well as bone pain and weakness. So why is this all important? Is because mast cells can confuse us in our diagnosis of why they're short of breath. Physical examination is key into trying to look for these rashes or anything that can lead us to mast cell activation. Tryptase blood levels will help us, as well as maybe looking for histamine in our urine, overproduction of histamine cells. Biopsy of these skin rashes may also lead us to finding excessive mast cells. So how do we treat patients who have mast cell activation? Well, you try to avoid whatever the triggers are. So whatever is causing our allergies or any of our histamine pathways to be activated, you want to avoid that. You can treat it with antihistamines. As I'm learning now is that when you have mast cell problems, you want to use both antihistamines as well as H2 blockers so that you can block both pathways to prevent patients from having histamine release. Biological injections. So we're starting to use those in the world of pulmonary in terms of allergy shots. I don't know if you guys have heard of Xolair, Dupixent. Xolair has actually been well studied in this area because they tend to block IgE levels very well. Cromolyn sulfate is also used if mast cell production is at an overabundance and that H2 blockade and antihistamines are ineffective. Sometimes we use steroids as well as epinephrine for patients who are anaphylactic. So briefly, like I said, I wanted to talk to you guys to identify patients who have dysautonomic problems, right? So patients who have an imbalance of the nervous system, those need to be addressed as soon as possible, right? Because, like I said, not all shortness of breath comes from the heart or from the lungs, so we have to look for other problems that could potentially be causing shortness of breath. And that not shortness of breath comes from the heart or the lungs. Who has questions today?
Is there any organ system that you feel predominates in this condition?
For mast cells? So we look at the lining of the skin. So skin has a lot of endothelial cells. The lungs have it as well as the GI tract. That's why in this case I tried to outline the abdominal pain as well as the manifestation of shortness of breath. The issue here is that this probably would, her symptoms probably were caused by the car accident. Probably a stressful event that cause her to go into an imbalance of her nervous system. Yes, doctor.
So would you use antihistamines or would you use something like singular?
Yeah. So usually the recommendations in the office that we're using is like Zyrtec plus Pepsid or Famotidine. So you block not only the histamine pathway, but you want to also block the H2 pathway as well.
How long does it take for them to respond?
Well, again, if you try to get rid of the offending agent, which is what you want to do to prevent full-on anaphylaxis, hopefully sooner rather than later. The problem is that, like I said, with autonomic dysfunction, I'm learning that treatment actually takes a long time. So they have to be persistent. Dr. Colombo and Dr. DiPace and I are working on a patient right now who is very difficult. And she's calling me every day, and she says nothing is working. But she just started the therapy 2 weeks ago. So it's a very slow and tedious process. So you have to try to get your patient to buy into this type of treatment.
Would there be a place then for referral for mental health services? PTSD might be a component with that trauma from the motor vehicle accident, at least if not anything else to mitigate our perception of the shortness of breath.
Of course, I think that is beneficial, but again, I think the key is what I'm learning is to try to get the nervous system to come back into balance, and then once that is fixed, then everything else should fall back into
Well,
place.
since that takes time,
Time.
perhaps some type of
Sure.
behavioral counseling would help in the interim.
Well, that's it. In the interim, that's why I saw the patient, is to try to relieve shortness of breath in the event if there's any type of asthma or sleep apnea or any type of allergies that maybe I could just treat superficially. But the problem is, right, we're just putting Band-Aids and not fixing the underlying problem. So the key is to treat the underlying problem. All right, well, so I said, I'm the introductory lecture, and we're going to follow up with Dr. DiPace, Dr. Colombo, and Dr. Soloway, who will give you more updates in regards to autonomic dysfunction. So stay tuned, because it really, once I started learning this, it changed your whole perception of how medicine is. All right. Thank you very much for having me.
So thank you very much, Dr. Cunanan, for such a great talk about something which I learned a lot about from knowing pulmonary disorders related to autonomic disease. The next speaker we have is Dr. Nicholas DiPace. He's a cardiologist and a good friend of mine. His specialty is in cardiology and autonomic disorders. Based in New Jersey, he is a medical director at Jefferson Heart